All right, last of the videos here. In this video, we will discuss endocrine disorders. Some of this is review, so I'm not going to spend a lot of time on some of these slides because in a lot of ways, well, for one, this content I've already covered specifically. You'll recall we've already discussed how the endocrine system orchestrates cellular activity, the key is feedback mechanisms, etc. And we will, as it's indicated as we go through this content, talk about specific genetic components that are relevant. So I'm not going to spend a lot of time on some of these slides. I wanted to show this to you so you could see the relationship between a protein, such as these proteins here that lead to and form growth hormone, but then a slightly larger cluster of proteins that have a peptide cleaved from them produce something like acetylcholine, and then another group of amino acids cleaved off of that can produce thyroxine, which is related to levothyroxine and thyroid hormones. And then you have a cholesterol molecule here, and the cholesterol molecule can form a variety of different steroid hormones and amino acids, things like epinephrine, norepinephrine, things like that. And, even fatty acids like retinoic acid and prostaglandins. I just wanted you to see kind of how those things can be related from a chemical structure and then how they would manifest in different chemicals. But I don't expect you to memorize that slide. This should look familiar because I've shown this to you already. This is from your book, and it basically shows you the different hormones, the organs that they're related to, that they act on, and that way that then feeds back either to the hypothalamus or the posterior or anterior pituitary, depending on the respective mechanism. We'll talk about those some as we get into them. This is a condensation of that chart. So this is the way I want you to start thinking. As you will recall, I said this earlier, our hormones and our endocrine system is designed to keep us between the lines, if you will, on the highway. It's designed to keep the body within normal range, knowing there's going to be variations from different conditions, different times in life, and different circumstances. The hormonal system, the endocrine system is designed to keep us in the middle. And there are conditions that are a result of those hormones performing, those glands, those hormones, those endocrine systems performing outside in excess of their normal function or deficient in their normal function. And that creates diseases and conditions. And essentially, what you have is with each hormone, you have a condition that reflects its excessive production and a condition that reflects an inefficient production or insufficient. So moving across the board here, too much antidiuretic hormone, syndrome of inappropriate antidiuretic hormone. We've talked about some of the effects of that. And then too little antidiuretic hormone leads to diabetes insipidus, which is manifested by a large amount of urine output. So syndrome of inappropriate antidiuretic hormone, retaining too much fluid, diabetes insipidus, peeing too much, peeing too little, peeing too much. And there are, granted, other sequelae associated with those conditions, but that gives you the idea. Growth hormone, you have two conditions, acromegaly, which is conventionally referred to as giantism, and then dwarfism, where people have insufficient growth hormone, so they don't grow to what is relatively normal stature for a Homo sapien. With acetylcholine, then you have an excess which produces Cushing's, and insufficient Addison's, or insufficient acetylcholine, which produces Addison. So you see where we're going here. Too much thyroid, Graves' disease, ultimately thyroid storm, and too little hypothyroidism. And with testosterone, estrogen, and progesterone, depending on the gender, where those are in excess or insufficient will depend on the symptoms that manifest. Excess estrogen in males will produce feminization, excess testosterone in females, virilization. And in some aspects of medicine now, this is a direction people are going intentionally for reasons associated with what is referred to as gender correction. So we'll touch on all of those things going forward from here. I've already shown you this slide, so again, not going to go into detail. These are hormones that are generated from the hypothalamus, so this should be familiar to you already. I've introduced this information already to you. And then these are hormones that are generated from the pituitary gland, either the anterior or posterior pituitary. So this shows you the source of those. You'll see the the pituitary gland referred to as the hypophysis. You may hear the anterior hypophysis or posterior hypophysis, means the same thing. So the anterior pituitary is where acetylcholine, TSH, and growth hormone for our conversations originate. We're not going to spend much time on FSH, and we're not going to spend any time really on FSH and LH. With hyper growth hormone, that produces giantism. So the hypophyseal plates don't close on the bones, which means they continue to grow. That hormone, growth hormone, continues to be secreted from the anterior pituitary, and individuals grow beyond normal body habitus. And I'll have some examples in class to illustrate what is meant by growth beyond normal body habitus. But everything gets bigger: fingers, joints, internal organs, heart, lungs, obviously muscles, bones, height, etc. And then dwarfism is also referred to as hypopituitarism, which is just the opposite, in which people manifest with small stature and in some cases smaller organs as well. Now, the posterior pituitary is responsible for the production of antidiuretic hormone as well as oxytocin. Our major focus is going to be antidiuretic hormone, also referred to as vasopressin. And when you have too much antidiuretic hormone, that condition is called syndrome of inappropriate antidiuretic hormone. In other words, we've got too much when it should be normal. That is going to cause an increase in sodium and urine retention, which is consequently going to attempt to lower serum osmolarity and keep a patient more hydrated. Whereas diabetes insipidus, unrelated to diabetes mellitus, diabetes insipidus produces an unplanned increased output. So these patients, and by increased output, I mean 3 liters an hour. Patients will put out a ton of urine and potentially have issues like hypernatremia and other symptoms associated with dehydration. Commonly, these kind of problems are sourced from tumors, closed head injuries, or some kind of neurological insult. Whereas issues related to giantism or dwarfism are generally genetic in nature. There is a gene that's expressed that causes acromegaly or hypopituitarism, and it's not a result of a tumor or cancer. It's a result of a genetic phenotype. Thyroid disorders are related to changes with thyroid hormone. Now, thyroid hormones T3, T4, and calcitonin are the main ones that come into focus for us. And in order to form these hormones, individuals have to have sufficient iodine. That iodine in the bloodstream is essential for the production of thyroid hormones. Thyroid stimulating hormone comes from the anterior pituitary and stimulates the release of thyroid hormones. So thyroid stimulating hormone is not necessarily dependent on iodine levels. But obviously, if iodine levels are insufficient, you can have thyroid stimulating hormone. If you're not making T3 and T4, there's not going to be any output. Now, here is a distinction I want to be clear in your head. So I want you to be familiar with the differentiation between T3 and T4. And that is T3 is more potent. It's relative to its companion T4, and it has a more rapid effect. So it is responsible for adjusting our metabolic processes, either being secreted and accelerating basal metabolic rate, or backing off and then subsequently there being a slowing down. So T3 is responsible for increasing basal metabolic rate, thermogenesis, heating us up, and facilitating cell replication think about like the context of healing. T4 is more of our homeostatic thyroid component. It's responsible for steady state maintenance and keeping us, as I mentioned before, using that driving illustration, keeping us between the lines. Calcitonin is is secreted in response to calcium levels and helps facilitate calcium deposition in bone. So when we're trying to form and strengthen bones, our body, in response to those kind of developmental signals, secretes calcitonin in order for calcium deposits to be made into bones so that bones can grow, and in the case of injury, so that bones can heal, and could potentially create consequently a decrease in serum calcium if that secretion is happening at an appropriate level. The thyroid gland is situated here in the neck. You'll remember, I want to call your attention back to when we talked about electrolyte disorders, specifically those related to calcium and phosphorus. We were concerned about patients who had neck surgery when we were talking about those electrolytes. So while we're also concerned when someone has neck surgery about calcium levels, not only are we concerned because of the effect on calcitonin, but we're also concerned about the effect of those neck surgeries on the thyroid gland, as well as the parathyroid gland. So the parathyroid sits on the thyroid gland. So neck surgery, I want you to have this buried in your brain and instilled in your brain, is when we have neck surgery, we are concerned about calcium and phosphorus, all of the other things, bleeding risks, airway, yes, yes, yes. But we also have a concern about electrolytes such as calcium and hormone levels such as thyroid hormones as well as calcitonin. So those are things that can be relevant to that patient's care and relevant things to monitor. This is an example, an illustration of the hypothalamic pituitary thyroid axis. So what you have here are you have the hypothalamus, the thyroid, and the liver. And then you have the mechanisms that signal, either by neurotransmission or environmental perception, circumstances that signal the release of thyroid releasing hormone, stimulating thyroid stimulating hormone, which can signal the release of T3 and T4. Notice that T4 is metabolized in the liver, so that is partially explains its more homeostatic component, whereas T3 has an effect on target organs. So if you think about something simple like encountering cold, you're warm and inside, and for some reason you get locked out of your house or whatever, you experience cold, and you notice that as you get cold, you start to shiver. Well, that is the neurotransmitters signaling your hypothalamus to signal the pituitary to release thyroid stimulating hormone to your thyroid to stimulate T3 to increase your basal metabolic rate as well to help warm you up, but also to help stimulate. It also signals your muscles to cause you to shiver, which is a mechanism of warming you up. When you go back inside, you finally get the keys to your house, and so your body then senses the change in temperature and you begin to warm up. Then this neurotransmission is stopped, thyroid stimulating hormone is stopped, and so that release of T3 subsides and you warm up because you had T3 to warm you up, but you quit shivering because now you are warm. That's the negative feedback mechanism. So it kind of gives you a very simplistic idea of that feedback process. When we're evaluating the thyroid, there are a few tests we can do. The serum tests are TSH, serum free T4, T3 and T4, and then T3 resin uptake, as well as thyroid antibodies and radioactive iodine uptake. These top tests tell you about thyroid function, TSH, T3, T4. They tell you about thyroid production. The thyroid antibodies tells you basically the antibodies that are released they're related to thyroid function. And then radioactive iodine uptake is a test that's used to see how that organ is functioning. This is a functional study. We give a radioactive iodine and then we use nuclear imaging to see how well that's been taken up into the thyroid and utilized. These give us an idea of what kind of issues we may be encountering with the thyroid. But like we did for the liver, sometimes we need to be more specific and more granular in that test. So we may have to do a thyroid scan, radio scan, or centiscan to get an idea of what the shape, size, and conformation of the organ is. We may have to do a serum thyroglobulin to give us an idea about function. And then we may also ultimately need to do fine needle biopsy to take a portion of the thyroid and see what the cells actually look like, if there's some kind of mutation, growth, abnormality, or whatever. Now, note that there are some medications you're going to commonly see out there. So this is not, while it's not a complete list, it's a list of some common culprits that you're going to encounter that can alter tests. So these are medications that may need to be held the day of the test. Now, a footnote, however, is that amiodarone being held the day of the test is actually not, I don't know how effective that's going to be. Apologize for that. Because the half-life of amiodarone is so long. So it could be that simply holding the test, holding the amiodarone dose may not be that effective. You'll have to ask when that comes up. But aspirin, Tagamet, cimetidine, furosemide, heparin, lithium, phenytoin, propranolol, all these medications might need to be held the day of the study. So some examples of thyroid disorders. Congenital iodine deficiency is referred to as cretinism, and that's a picture that I have here on the right, which is exemplified by this distended abdomen, the protuberant abdomen. You can see the herniated umbilicus. Usually the tongue is protruding, wide set eyes, and kind of a listless gaze. This is a condition that was more prevalent before a very simple change was made in the production of salt. Prior to that change, some women in certain areas were not getting sufficient iodine in their diet to take care of their needs as well as the fetus's needs, and children were admitted or born with this congenital iodine deficiency. That's one example. Hypothyroidism is another manifestation of a thyroid disorder. I've got a slide here that's going to illustrate some of these. Hyperthyroidism, we're going to discuss. Thyroiditis is inflammation or irritation or infection of the thyroid gland. And the treatment is going to, of course, depend on the cause. If it's inflammation, there'll be steroids involved. If there's infection, we need to treat the infection. The outcome of the ultimate thyroid function will have to be ascertained once the thyroiditis is corrected. And thyroid goiter, here's an example here, is an abnormal growth of the thyroid gland that may or may not affect overall thyroid function, but it does have a rather unpleasant appearance. And then, of course, thyroid cancer. And thyroid cancer can have a couple of manifestations. It can produce either a hyper or hypothyroidism. Hyperthyroidism, commonly referred to as Graves' disease, it is the most common form of hyperthyroidism. And it is characterized by people who tend to be warmer. They have a lower tolerance of heat because since they have hyperthyroidism, they have a higher metabolic rate. You can see some of the clinical manifestations down here. Nervousness, rapid pulse. They may be tachycardic, but they may just have a higher baseline. Their baseline resting heart rate might be 90, 95, or even over 100. They don't like heat because they already feel warm enough. Think of all the things that are associated with everything being up too high. So tremors, skin flushing, warm, soft, moist skin. As it worsens in severity, exophthalmos, which is a protrusion of the eyes. You can see that depicted here in the top image. This woman is not bugging her eyes out at you. She has exophthalmos as a result of her hyperthyroidism. In this particular case, this is a picture from when she was diagnosed at the clinic or wherever she was being seen. She was diagnosed with hyperthyroidism. And you can see after correction of her Graves' disease, her eyes return to normal. That's the bottom picture here. So exophthalmos can be reversible. That, of course, depends on the severity and length of time that the hyperthyroidism has existed and not been treated. One concern there associated with exophthalmos is these patients sometimes will complain of dry eyes because there are times when they can't even get their eyelids all the way closed. So that can be another problem as a result of this hyperthyroidism. They will have increased appetite, perhaps weight loss, elevated blood pressure, cardiac dysrhythmias. And the cardiac dysrhythmias become concerning and make hyperthyroidism life-threatening as it manifests in some of these more severe manifestations or presentations. So thyrotoxicosis, which is basically an excessive amount of hyperthyroidism, can result in what is referred to as thyroid storm. And patients end up with resting heart rates in excess of 140. They have a higher propensity toward lethal arrhythmias. They can be severely hypertensive, sustaining pressures for hours if left untreated in the 200s easily. So that can be very critical, and patients in thyrotoxicosis or thyroid storm will often be admitted to a cardiac or medical surgical ICU because they're going to need some kind of higher level of monitoring and possibly even an infusion of an antihypertensive drug, vasodilator. Commonly, Graves' disease is connected with an autoimmune disorder, and that means that there may be a steroid component when the immune system gets kind of carried away and begins to attack itself. Part of the treatment may involve steroids, but that also means that it's not necessarily reversible like an infection or something like that. It is 8 times more frequent in females than in males. Sorry, ladies. The medical management of hyperthyroidism is going to vary. There are some medications that can be used to try to block and inhibit the synthesis of thyroid hormones. Propylthiouracil blocks synthesis. Methimazole inhibits the synthesis. So those two work to decrease the amount of drug that's put together. Sodium or potassium iodide solutions can be given to suppress the release. So these iodine solutions discourage the gland from actually releasing thyroid hormones that have already been produced. So these drugs, along with dexamethasone, work after the synthesis has happened, whereas propylthiouracil and methimazole prevent the synthesis of the drug. Beta blockers are used primarily for management of tachycardias and those hyperactive symptoms associated with hyperthyroidism. The radioactive 131I, 131 being being the atomic number for iodine, and related to its electrons. But radioactive iodine therapy can be used to try to blunt the activity of the thyroid gland. So in that case, what they're trying to do here is either by injecting the thyroid, they're trying to inhibit a portion of that gland's function so that it basically does not work and doesn't produce as much thyroid hormone. You may see everything from ablative therapy, where they try to ablate a portion of the organ, to a subtotal thyroidectomy, to a total thyroidectomy. So the idea here is we try to do things to maybe take part of the thyroid gland or injure or damage part of it. So this is all discussed with the patient, and commonly what will happen, or at least this is what I've known of to happen, is patients will kind of balk at the idea of getting a radioactive isotope administered. And the notion of having a partial thyroidectomy doesn't appeal to them either. Because the answer to that is, the question there is, well, what happens if we do a subtotal thyroidectomy and I still have this problem? Then we're back to another surgery. So some people will elect to have a total thyroidectomy and then just commit themselves to replacement therapy, supplement therapy for the rest of their lives. So that's a common approach, which is quite pragmatic if you look at it from a patient's perspective. Hypothyroid is the opposite. So in this case, 95% of the cases are primary hypothyroidism, which means there's not another cause. In other words, there's not been an injury to the thyroid gland. There's not been a disease of the thyroid gland. There's not been cancer or any other type of condition like a drug that has damaged the thyroid gland. It just happened on its own. And the severe manifestation of that is referred to as myxedema, which is a profound, it's the thyrotoxicosis of hypothyroidism, if you will. It's a severe manifestation. The causes of hypothyroid are Hashimoto's is most common. Next behind it being atrophy, and then medication adverse side effects. So of the non-primary hypothyroidisms, Hashimoto's is the most common. The symptoms associated with it are just the opposite of hyperthyroidism. So these patients manifest with fatigue. They gain weight because their metabolic rate slows down. Since their metabolic rate is slower, they're cold all the time. So they're more sensitive to cold. These are patients whose room you go into and it's 95 degrees in the room. They may be more lethargic and listless and be more prone to mood swings because they have a depressive component to this whole experience. And the treatment, while this doesn't sound necessarily intuitive, the treatment can be similar. Radioactive iodine to try to suppress the function of the gland, or thyroidectomy to remove it because it's not responding appropriately, and thyroid supplementation. So one approach may be, which is sometimes challenging to manage, is to not do anything to try to finish off, if you will, the functional portion of the thyroid gland, but to add supplementation to try to normalize their thyroid levels. The challenge with that is not knowing what kind of function you're getting out of the thyroid gland that's there. That can make management very challenging and dosing very difficult. So often people will again have a thyroidectomy or radioactive iodine to ablate the organ and then supplement with either Synthroid or levothyroxine. So thyroidectomy, we've touched on it already. It is the treatment of choice for thyroid cancer because thyroid cancer can be metastatic, and it's proximally located to critical organs, which can create some real challenges. This can look like a modified or radical neck dissection, and then possible radioactive iodine to minimize any metastasis. So there may be some radioactive iodine depending on what the tissue looks like once it's extracted. Postoperatively, our goals are going to be to minimize the stress and anxiety in the room, trying to avoid irritation or precipitation of thyroid storm. And we're going to be doing dietary guidance to meet patients' metabolic needs because that's going to have changed now that their thyroid is gone and they're on supplementation. There are going to be medications that interact with the thyroid supplementation. Digitalis can decrease the effect, anticoagulates can potentiate them, antacids can interfere. Sedatives, sleep aids they may have taken before, they may need less of or more of. It depends on where they're coming from, because hypothyroid patients are going to have had less and now their supplementation gets them in closer to a normal range. That's going to have a different orientation toward diet and activities than those who were hyperthyroid and had their thyroid gland removed. Think about coffee as a simple example. If you were hyperthyroid before, you may not have needed caffeinated beverages. In fact, you may have been avoiding them for fear of inducing arrhythmias. Whereas if you were hypothyroid before, you might have been drinking a pot every morning just to feel like you can get through your day. And so there may be some changes. You see where those changes would be, those modifications would be different depending on the orientation, the direction from which those patients are coming. Postoperatively, airway is primary because the operative interventions have been in and around the major airway structures. So airway breathing, those are number one. Bleeding, number two, because we've obviously we're in the area of the neck, we're in the region in very, very close proximity to the major vascular structures that are the carotid arteries and the jugular veins. So we have to be very attentive to bleeding and possibly hematoma formation. Hematoma formation can put pressure on those major vascular structures. So they may not be bleeding out, but they're putting pressure on the inside. So monitoring the dressing is important, particularly the posterior dressing, because people are usually sitting in a formation of the Fowler's position, which means blood is going to tend to be directed toward the back. So we're going to be assessing patients for pain and providing pain relief medications, and be attentive to the patient's response to those medications. What was an effective dose before may not be now, or may be too effective. I mentioned the semi-Fowler's position because we want to support the head and neck. That's the position we want them in for optimal breathing and support, so that we actually try to avert injuries secondary to surgery. We want to be assessing the voice as far as our daily assessment to make sure the voice is clearing, to be monitoring for any kind of vocal cord or airway pharyngeal injury. But we want to discourage talking. We don't necessarily want these patients talking a lot. That may mean minimizing visitors for these people. And also being attentive, as we've mentioned before, to calcium and phosphorus related issues because of the relationship of calcium to the thyroid and the way that the thyroid secretes calcitonin, and the parathyroid glands and parathyroid hormone also affect calcium and subsequently phosphorus levels. So those are all important components related to this kind of neck surgery and thyroid surgery. This slide should be familiar to you. This is the same information about hypocalcemia and the effects of it. Not going to go back over this. This is should be common knowledge for you at this point. So the bronchospasm, Trousseau sign, laryngeal spasm, Chvostek sign, all this stuff you've heard before. Now the parathyroid glands are four glands that sit on the posterior thyroid gland and commonly can be affected by, obviously, surgery to the thyroid gland. And parathyroid hormone regulates calcium and phosphorus as well. So increases in parathyroid hormone elevate blood calcium and increase calcium absorption from the kidney, intestine, and bone. These, while they increase serum calcium, lower phosphorus levels, this should sound familiar to you from previous lecture. This slide summarizes the effects of parathyroid hormone and thyroid on calcitonin and calcium. So this, again, review information for you. I'm not going to go back over it. This picture just illustrates for you where the parathyroid glands sit in proportion to the thyroid hormone and the cricoid bone in the neck. Hyperparathyroidism occurs about two to four times more often in women than in men. And its manifestations, the patient can have no symptoms, and they can be very vague and nondescript or attributed to other things. So you notice hypertension and constipation. There are a variety of things that can produce nausea, vomiting, and constipation, as well as hypertension in the absence of any specific symptom. It could just appear that they are just hypertensive. And apathy and fatigue and muscle weakness can be a side effect of some antihypertensives, such as beta blockers. So if there is a problem with hyperparathyroidism, the treatment is removal of the parathyroid tissue and hydrating the patient. Hypercalcemia is also a potential side effect from issues with both the thyroid and parathyroid gland. This should look familiar to you. This is the same content from earlier in class when we were talking about hypercalcemia. So again, this is all fair game related exactly. We touched on it earlier, and it's just coming back around full circle. And here again, more content from before about hypercalcemia. Now, one thing we didn't touch on is hypercalcemic crisis. When the calcium gets very high, this can cause neurologic cardiovascular symptoms and can be life-threatening. So this can be a quite severe manifestation of high calcium. So the approach here is going to be rapid infusion with isotonic solution. We want to dilute that calcium, and we may also be adding corticosteroids to reduce serum calcium by trying to drive calcium deposition into bone. It's trying to shift that calcium into other cellular structures. Could be one of the objectives there. Some of the causes of hypoparathyroidism: abnormal parathyroid development, destruction of the parathyroid gland from surgery. Think about, we go in to do a thyroid surgery and we injure the parathyroid glands because they're so small and right there. Vitamin D deficiency can also do it. The way that's going to look, patients are going to manifest with symptoms associated with calcium: tetany, numbness, tingling in the extremities, stiffness in the hands, feet, bronchospasm, laryngospasm, EKG changes, etc. This is another slide for hypocalcemia. Again, this one associated with the parathyroid gland, but again, same content. So how are we going to manage this? We want to maintain serum calcium between 9 to 10 milligrams per deciliter. We may be giving calcium gluconate in an emergency situation if there is extreme hypocalcemia, but we're going to give that slowly. Anytime we're administering electrolytes, we're going to give that slowly. You may see phenobarbital used to decrease neuromuscular irritability. This helps calm the neuromuscular cascade down and allay some of those symptoms. We want to have a quiet environment, preferably no drafts or bright lights, sudden movement, and provide a diet high in calcium and low in phosphorus and high in vitamin D. So with the adrenal glands, issues primarily arise from hormones secreted by the adrenal cortex. The adrenal medulla functions as a part of the autonomic nervous system, so it releases things like catecholamines, epinephrine, norepinephrine, which stimulate that fight or flight response. And then the adrenal cortex mediates the glucose and mineralocorticoids, as well as your androgens like testosterone. So the symptoms are going to be symptoms associated with those hormones. This slide just reviews the anatomical structures and the placement of the adrenal glands. Now, adrenal insufficiency, which is a low production of the adrenal corticosteroids, 80 to 90% of that are primary adrenal insufficiency, or what's referred to as Addison's disease. It's usually autoimmune in origin or atrophy of the tissue, except for cases such as TB and histoplasmosis, which can damage or injure adrenal tissue and induce adrenal insufficiency. There are medications that can also cause adrenal insufficiency. Here are some examples. I want you to know this about rifampin, dilantin, and phenobarbital, that they can induce adrenal insufficiency. Also, overuse of steroids. So if people are using steroids, think about people who use them for weightlifting or whatever. If you're using steroids and supplementing, sometimes the glands will say, we don't have to do our job anymore, so we'll just quit, and the organ will atrophy. As a result, what you might see from adrenal insufficiency are things like muscle weakness, decrease in appetite or anorexia, GI symptoms, nausea, vomiting, for example, fatigue, dark pigmentation of the skin and mucosa, low blood pressure, low blood glucose, low serum sodium, high potassium. And if severe enough, you may see Addisonian crisis, which is going to look like cyanosis, nausea, vomiting, shock, confusion, and restlessness. So that would be Addisonian crisis. In my 30 some odd years of nursing in critical care, I've not seen Addisonian crisis. Or maybe once or twice, just very rarely. So our diagnostic tests here are going to be evaluating the adrenal cortical hormone levels, That's ACTH, and then performing an ACTH stim test, which tells us how the body responds to the administration of acetylcholine. Corticosteroid therapy is going to be a portion of the care and management here. It's going to suppress the inflammatory and autoimmune response, and it's one of its effects and purposes is to control allergic reactions and actually reduce transplant rejection. So that as a portion of therapy, because they have insufficient corticosteroids, we've got to replace them. And the specific medications that we use are going to be referenced in table 45.4. It's going to be important that the patients are consistent on timing their doses. There are a lot of medications that you can take at 6 o'clock in the morning, and then the next day you can take it at 9 o'clock or 10 o'clock or something like that. In this case, again, the steroids are designed to keep us maintaining normal biologic functions. We're going to want to keep those doses timed pretty consistently. If you take it at 6 o'clock in the morning every day, you take it at 6 o'clock in the morning every day. If it's 8 o'clock, that's what you do at 8 o'clock. So we want the timing of the doses to be consistent. We also want patients to be taking the medication strictly as prescribed and not tapering the dose based on their symptoms, how they feel, if they're feeling good this day, or what they've read on the internet. The tapering is going to need specific monitoring and done in a very staged, like an intentional way. So we don't want patients doing those kind of things on their own, adjusting their dose based on whether they're sick or how they feel, or if they feel great or if they feel terrible. So we want to educate people to the side effects. One is to educate patients about their susceptibility to infection. So think about patients who have conditions like this and possibly have concurrent illnesses such as COPD, and adding a corticosteroid is going to further complicate their immune response and run the risk of pneumonias. So for the assessment here, we're going to try to note any illnesses or stressors that can precipitate other problems. So remember that we talked earlier about how stress and anxiety can mitigate your own immune response. So we want to teach people coping skills and ways to identify illnesses early and coach in them a rapid response to onset of symptoms. So you might need to see a doctor a little more frequently or a little sooner than you might have before you started treatment for adrenal insufficiency. Fluid and electrolyte status is going to be important because we know that those adrenal hormones can affect fluid status. We want patients to be attentive to peripheral edema and symptoms associated with different electrolytes, such as irregular heartbeats and things such as that. They're going to be sensitive to orthostasis and orthostatic blood pressures, orthostatic hypotension. So patients need to be educated about what normal vital signs are for them and what that might be a normal response to their blood pressure dropping in response to their treatment, which may mean they have to make modifications like getting up and moving more slowly, more intentionally. We also want to educate them towards signs of adrenocortical insufficiency. So if perhaps the dosages of medications, the treatment that they're on is not being efficient, is their weight going up? Are they retaining fluid? Are they having muscle weakness? More fatigue? Has that increased? And this comes back to educating them about their medications and the effects the medications are having, and then educating them about the signs and symptoms of Addisonian crisis. Now, with the addition of this, in the presence of Addisonian crisis, patients may also have hypoglycemia, because remember, those corticosteroids can increase your sugars. So educating about hypoglycemia and when they're in treatment, when they're being managed with their steroids, how their sugars can go up. And it's still going to be important for them to manage because hypoglycemia can be a real problem. Some of the issues concerning with having been diagnosed with adrenal insufficiency is there are some issues that come up with disturbance of body image, and that's things like hyperpigmentation of the skin that it doesn't necessarily show up in places that can easily be hidden. So that is something that patients may find displeasurable and disconcerting. So there may be some education with that in preparation for that. They may experience self-care deficits from the weakness, fatigue, and muscle wasting, as well as altered sleep patterns. They are at risk for injury from the weakness, and we've already mentioned fluid volume issues, as well as activity intolerance, and I've already discussed risk of infection. So a good deal of information to educate people to, and some not necessarily straightforward, intuitive, and or simple information for patients to try to get their head around. Now, adrenal insufficiency, some of the interventions that we do for that is these patients are at risk for fluid volume deficit. So we're going to monitor for signs and symptoms of fluid volume deficit and encourage fluids and foods. So that said, though, as they may be at risk for deficit, we also have to watch in case they're overcorrecting because they don't have the normal mechanism to keep everything balanced. And so in this case, we're going to be looking for foods that are high in sodium. Now, one thing I want to call back to is, if you recall, back in the beginning of this semester, we were talking about hyponatremia and conditions that were consistent, that there was one condition that was commonly associated with lone hyponatremia and wasn't related to dilution, it was related to salt loss, and that's this one, adrenal insufficiency or Addison's disease. So I just want to call that back. That standout as being the only thing that causes something, that's a great test question. So those are great kind of little nuggets to draw out in some form or fashion. So these patients, we want to avoid stress in because of their activity intolerance. That doesn't mean that we want them not doing anything. We want them maintaining a non-stressful environment, but remember, moderate or reasonable exercise is beneficial to help maintain stress and overall mental health. So it's not we want them to be docile all the time. We do want them moving, but we don't necessarily want to get them started at CrossFit or something like that. Patient education is important about the medication regimen for the examples we've talked about already, and it's going to be a lifelong process. This is not something that's going to last for a month or 6 months or a year. This is going to be the rest of their life. And they'll need to discuss with their physician when they have stressful situations how they should moderate their dose of their medications, and if they should. There'll be times those steroids can really ramp up emotions, so there may be times where, in anticipating difficulties, if they come upon a situation where they're going through a divorce or something, there may be times where they may adjust their dose to kind of ramp things down a little bit to help cope with that whole situation. So that's an example of where that would apply. And also, a part of their education process would be educating them about the steps to identify and help prevent adrenal crisis. So those are going to be important things for them to know going forward. Now, Cushing's syndrome is the other end of the continuum here. Remember, it's usually one thing or the other. And in this case, this is where you have patients who have excessive adrenal cortical activity, or excessive corticosteroid medication. So in this case, they're already in a ramped up situation with respect to their corticosteroids. So these patients may have hyperglycemia. They may have toward central type obesity. Think about the manifestations of cortisol. That's what you want to think of here, not necessarily corticosteroids like getting buff. Those are steroid hormones, but corticosteroids like stress response kind of thing. So as we get stressed, persistent stressful situations will tend to make our body weight go up and push us toward hyperglycemia. So you can see where those things can be concerning. There's a typical characteristic buffalo hump that has to do with fatty deposits in the back. And I'm going to show you a picture of that in a minute. And then can become fragile. I'd like to have you think about patients who are on chronic steroids for respiratory disorders. Their skin gets real fragile and they have skin tears quite often. Well, it's because they're taking steroids for their lung condition. The same is true with patients who have Cushing's syndrome, except they're not taking the steroids, they're making the steroids. So they may have sleep disturbances from the stimulant effect of those steroids, osteoporosis, muscle wasting, hypertension as opposed to hypotension, moon face, this rounding shape of the face, which happens with patients who are on transplant, who have received organ transplants or are on immunosuppressive medication. Again, these patients are making their own immunosuppressive medications. They may have slow wound healing, acne, virilization in women, loss of libido, mood changes. You can see where there's some significant issues here that may contribute to mental health issues. One of the diagnostic tests we use for this is the dexamethasone suppression test. This is a depiction of some of the common manifestations related to Cushing's syndrome. You see in the schematic here on the right, you see the buffalo hump. This particular picture, the artist has included all of the potential symptoms. The abdominal weight gain, the thin skin, which produces easily bruising skin, kind of a redness to the cheeks, that kind of flushing, a pendulous abdomen from that weight gain, the thin extremities. And some things they didn't represent were the hirsutism and striae that can result. So here's striae across the chest from that excess weight gain and the strain on the skin, and then the hirsutism or the hair growth as a result of the excess steroids for these individuals. So as you can see, this perhaps doesn't reflect someone's characteristic ideal representation of themselves. So with this, we want to assess their activity level and their ability to carry out self-care, what aspects of these manifestations make it difficult for them to care for themselves. Ongoing skin assessment. I have some examples that I'll discuss in class where there were skin and underlying tissue issues as a result. I've just mentioned the changes in physical appearance and how that may affect mental and emotional status, as well as the effect on libido. Those things can definitely have a pretty significant challenge for patients. These patients are at risk for injury or infection. Again, the slow wound healing together with the depression of their immune system can increase their risk of infection and the opportunity for infection. They have a potential for self-care deficit, and we've already talked about skin integrity and disturbed body image. So what we're going to do here as far as treatment goes is we may reduce corticosteroid use if possible. That may not be a part of the issue at all. So in that case, we may have to consider surgery, and that's partial resection of adrenal tumors or pituitary tumors if that's what's contributing. We may have to consider radiation to ablate one or part of the adrenal glands to help suppress that activity. Want to be careful about just going in and directly, off the cuff, removing the adrenal glands. That can be very problematic. The medications that you may see used out there are medications like mifepristone, which blocks the effects of cortisol and helps inhibit some of those inadvertent or unwanted effects of cortisol. May help the hypertension and other problems that they have as a result of their Cushing's. You may also see patients treated with ketoconazole, which actually helps decrease cortisol production. Those could work advantageously, and in fact, you'll probably see these drugs as one of the beginning treatments for patients with Cushing's syndrome. And as I've mentioned before, our goals and planning is going to be to help decrease the risk of injury and infection and maintain skin integrity, improve their self-care. They may have to be more meticulous about their skin care and more attentive to ways to preserve a positive body image and maintain a healthy mental function. So we may have to encourage these patients in the direction of intentional self-care activities to help improve their state of mind, to manage their, like is listed here, their emotional regulation is going to be key. Their medication regimen is going to also be important to help keep things consistent. Again, this is one of those conditions where the medication needs to be taken the same time every day, pretty regularly, and only make changes in consultation with the physician. Stress management becomes important for the reasons we've already discussed. And we want, for these patients, a diet that tends toward a higher potassium diet and lower sodium. These patients are not going to have issues with low sodium, like Addison's disease. So that kind of gives you an overview, and we'll flesh this out some in class. Again, just a dusting over the endocrine disorders, and hope you have a good break.